Okay, welcome everyone. Welcome the dear faculty, most respected Dr. Sushmita Banerjee from Kolkata, Dr. Pankaj Deshpande, my friend from Hinduja Hospital, Mahim, and our own local Gujarat, Dr. Fagun Shah. We also welcome the dignitaries who have been invited as the guests and the guests of honor. Today we have all assembled here for a very lively, our yet another Gujarat WhatsApp webinar, this time on pediatric nephrology in office practice. So we will have some 2 or 3 cases and some something on the labs and some important issues which may be appearing very silly day to day, but I think good to hear from the experts. And hopefully in the next 1.5 hours we will be able to finish our agenda. But as we have done in past, we are never in a hurry because we can, in case we are not able to finish, we can always have one more session. But let everything be crystal clear in details without going through or running through the agenda. So with that, I will hand over mic to Dr. Ramesh Bajania, who is the untiring and forever green administrator of the WhatsApp group of Gujarat. More than 4 WhatsApp group now they have been merged into 3, I think. And so he will address and introduce the guests today.
Yes. So, good evening, all respected seniors and dear friends. I welcome all to this pediatric nephrology webinar. The questions have been curated in such a way that the common pediatrician practicing in day-to-day office, he comes across these things. And we have tried to make it user-friendly in a way that preferably we don't show these slides. Later on, the recording can be viewed on Gujarat Pediatrician WhatsApp channel, so one can subscribe it. And next month, I invite all of you for our vaccinology part 2. So today we have got Dr. Raju Shah, an eminent personality, as a guest of honor. And not only he is my mentor, but a respectable figure across the nation. So Raju bhai, a few words of inspiration, please.
I'm sorry because of the internet problem. I'm
No
not
issue.
able
We
to
can hear
start.
you. We can hear you.
Okay. I'm not able to start my video.
No
No,
problem.
it's okay. It's okay.
Yeah. Thank you so much for inviting me for excellent web meeting. We are all used to this type of web meeting, as you know, Ramesh has started this group, and almost twice a month or so there are regular web meetings, and so many friends are really benefiting because of this. And evergreen Nitin is moderating these sessions in such a nice way that it is always not only knowledge but also some other aspects of the pediatrics as well as IAP. Both are also, we are getting some more knowledge about it. So I wish all the best and have a wonderful session today. Thank you for inviting me.
Thank you, respected Dr. Raju sir. Now, our next guest of honor is Dr. Ajay Srivastav. Dr. Ajay?
Yes, sir. Just 1 second. Thank you very much, Dr. Ramesh Bajania, and it's really my proud privilege to be here. This program, we are going through it. Just 1 second. She's my gynecologist and giving me missed call.
No problem.
So I would just rather say that there must be some call. हाँ ठीक है अभी आते हैं. So just to say a few words, like जिनके इरादे नेक होते हैं अक्सर साथी उनके अनेक होते हैं, और जिनके इरादे मेहनत की स्याही से लिखे होते हैं, जिनके इरादे मेहनत की स्याही से लिखे होते हैं, उनकी किस्मत के पन्ने कभी खाली नहीं होते. मैं दिस गुजरात व्हाट्सएप ग्रुप ग्रो और ये पूरी तरह से आगे चल के पूरी इंडिया को अपने साथ मिलाए. लुकिंग फॉरवर्ड टू दैट. अरे सर नितिन शाह सर, जब आप हो यहाँ तो फिर ये प्रोग्राम तो अच्छा होना ही है. और मैं आपका फॉलो कर रहा हूँ सर. आप कभी भी पिछले 20 साल, एटलीस्ट 22 ईयर्स, ओके, आई एम फॉलोइंग यू फॉर नाउ 22 ईयर्स. तो आपके सामने तो मैं आया, आपके सामने तो मैं बड़ा हुआ. क्या कहने, आप हमारे हमेशा मेंटर रहे हो और ऑलवेज गेटिंग इंस्पिरेशन फ्रॉम यू. और all the best to Dr. Ramesh Bajania and all the team. My special regards to Dr. Manmeet Sodhi. She was our review member in 23. Dr. Ramkrishna Paramahansa sir, Dr. Vasudeva sir, Dr. Raju Sasar, Dr. Gayatri Bejbarua, Dr. Sushma Madam. Yeah, Bala, hi, how are you? With the galaxy of your stalwarts, no? So this group is shining and shining every time. So इरादे नेक हैं, आपके चाहने वाले अनेक हैं. Let us carry on. Thank you very much for inviting me.
Thank you, Ajay bhai. Thank you so much. I welcome Manvit ma'am, Dr. Bara, Dr. Vasudev, Dr. Gayatri Bejbarua, Dr. Sushma Kirtani. So,
Ramesh bhai, before we start,
please.
let's also thank Dr. Trambak from Zidus for joining. And as you know, this webinar is possible only because the platform provided by Zidus. So maybe Trambak, say a few words from Zidus point of view, and then we can start the webinar.
Sure, sir. Thank you so much. So I am Dr. Trambak. I am the Senior Medical Advisor at Zidus Life Sciences, Ahmedabad, and I'll just take you through a very quick presentation, just taking just 2 minutes of all of your time. So talking about Zidus, it's a well-integrated pharma player with a proven track record with over 23,000 people impacting across 4 continents. We have around 300 plus generics and more than 1,400 research scientists working day in and out to launch products that address unmet healthcare needs. We have novel biologics like Lipaglyn, Exemptia. We have the India's first indigenously prepared quadrivalent influenza vaccine, that is Vaxiflu 4, Twinrab, which is a novel cocktail of monoclonal antibodies in rabies post-exposure prophylaxis. We have first-in-class breakthrough product Oxemia, which is an alternative for an oral alternative for CKD patients, Zycov-D and Bilipsa. So these are our major breakthrough products. And when talking about Zidus vaccines, we have collaboration with Etna Biotech and the Vaccine Technology Center right here in Ahmedabad. Quickly, the journey of Zidus Life Sciences in terms of vaccines, we started with typhoid and Hep B, then prepared the Vaxirab N, which is the anti-rabies vaccine, followed by Vaxiflu S, which was the influenza vaccine, the H1N1 only monovalent. And then we prepared the quadrivalent vaccine, Vaxiflu 4, and then Zyvac TC, which is the typhoid conjugate vaccine, followed by Twinrab and Zyvac MMR, which we have launched last October. So these are our few initiatives on the screen, which is the VCare is the most important, which takes care of all the activities to improve immunization rate in the country. We have also upgraded our needle of Vaxiflu 4 with Terumo 25G, which is now best in class. So now our quadrivalent influenza vaccine is updated. So thank you so much, and please continue. Thank you, sir. Thank you.
Trambak, that was really brief. If you can stop sharing. Yeah. So now I think we'll start with our webinar. Let me, I the proud privilege to introduce the panel. So we have myself and Dr. Ramesh Bajania moderating the session. And as Dr. Ramesh said, we will not show slides so that everyone can have attention to the speakers. It will be more on a question answer format. So we have Dr. Sushmita Banerjee. She is the consultant pediatrician and a consultant nephrologist at the CMRI in Kolkata and also attached to the ICH in Kolkata. She is a member of Senior Advisory Council of the Indian Society of Pediatric Nephrology, which is like the IP chapter of the Pediatric Nephrology Group. And she is also an associate editor for the journal, which is brought out with her. And she has been the past president of the West Bengal IP and many laurels to her credit. Welcome, madam. Then secondly, we have Dr. Fagun Shah, is a local nephrologist from Ahmedabad, and Dr. Fagun is having his own child kidney clinic in Ahmedabad. Welcome, Fagun. And last but not the least, we have Pankaj. Pankaj is my great friend. I mean, we work at Hinduja together for now more than 20 years. He's also attached to Apollo Hospital in Navi Mumbai, his own clinic at Navi Mumbai, and goes to several other hospitals nearby and rendering his pediatric nephrology services for last more than 20 years. So over to Dr. Ramesh now to start the webinar.
Yes. So Pankaj, we'll start with you.
Okay.
Most of the questions we have prepared considering the common pediatrician, right?
Yeah.
So many a times we all subject child for urine examination but the different
Ramesh bhai,
components
louder, we
of,
can't hear you.
but the different components of urine examination, sometimes they are not understood by pediatrician, right? So first of all, tell us that the morning sample is mandatory, or any sample during daytime also can work?
I think. So thank you for bringing that question up, because I think that's one of the things that people keep on advising. The short answer to it is it depends on what you're trying to look for. So for example, if you're trying to look for protein in the urine, you want the first morning urine sample. Urine routine is not the best test for looking for it anyway. But it has been shown that the urine protein is the lowest in the morning, and plus you get rid of the confounding factor of orthostatic proteinuria. Therefore, you want the morning sample. Similarly, if you have a child who's got polyuria and you're trying to find out if there is a problem in the concentration defect, then an early morning sample makes sense, because you've got a ready-made child who's been water starved for about 12 hours overnight, and an early morning osmolarity may give you some more hints as to what you're trying to deal with.
Correct.
If you want to look for calcium, previously the thought was that since the baby is or the child is lying down, so you have more calcium coming into the urine, and therefore it should be the second morning urine sample. But it makes no difference. I don't think there is a huge difference in that. When we advise for all the other conditions, a morning sample is not mandatory. In fact, a morning sample is going to be detrimental for your diagnosis. Why do I say that? There are two things that happen when you advise somebody to do a morning sample. The first thing is the parents are going to ask you, वो बच्चा 4 बजे उठ के पेशाब करता है, 6 बजे उठ के करता है, कौन सा पकड़ूं? And be glad that they will ask you in the clinic. Otherwise, they'll call you at 6 o'clock and find out, अभी पकड़ूं कि बाद में पकड़ूं? And then there are some smart parents who will tell you, रात में बिस्तर में पेशाब करता है, उसको पकड़ूं कि नहीं पकड़ूं? That's the first thing. The second thing is, now imagine a child has passed urine at 6 o'clock in the morning after getting up, and the parent has collected the urine after great effort. There will come collection of urine later. Now, this sample, what do you think the parent is going to do? It's going to sit at room temperature till the lab opens. The lab opens at 9 o'clock. So for 3 hours, the sample is sitting at room temperature on the table of the parent. Then the parent puts it in the pocket and travels in a bus or in the car and gives it to the lab.
So
And
Pankaj, how fast it should be tested, Pankaj?
we will come to that. So I want to point out that you are now relying on this sample to make a diagnosis and treat the child. So I think you can understand the problems that you are going to face when you are going to treat this particular child. Now, the other important question, so just for information's sake, since you are the person I can ask a question to, if you want to check for RTA and you want to check the urine pH, what time would you do the urine sample? Just a guess.
Any?
No. So we all know Nelson. We have read Nelson 10 times. And Nelson has very clearly told you urine pH less than 5.5, more than 5.5. What it has not told you, or what we have failed to understand, is it is at the time when the child is maximally acidotic. So which means that the time of the day doesn't matter. The clinical presentation of the child matters. So a child who's presented in a severely acidotic state with a bicarb of 8 needs to have a urine sample checked there. So as Katrina Kaif's song goes, right here, right now. So that's the time you have to do a urine sample. It's not waiting. You have given bicarb, next day morning, you're going to check the urine sample. It has no meaning, because you have missed the boat of differentiating between proximal and distal RTA. So I think the important answer for urine infection, you don't wait for the morning because of what I said in the morning. So any sample is fine in the daytime. It does not have to be a morning sample. So coming to your question about when the sample should be tested. So I think in an ideal world, urine sample given has to be checked immediately. And it is especially true if you have got dipstick and you're going to check for leukocyte esterase and nitrate. If you're not going to check it immediately, you're already confounding your results. Now, since that is not an ideal world that we have, half an hour, maximum 1 hour. 1 hour, you're pushing it because the cells lyse, which is the reason why post-infectious nephritis with microscopic hematuria has a completely bland urine, because the RBCs have lysed. You're not seeing the RBCs. And that's the reason why the sample has to be checked immediately. as soon as possible.
Okay. Now, they write the presence of protein. So, what is significant protein?
Correct. I said right in the beginning, urine routine is probably, or forget probably, it's definitely not the best test for urine protein, because I have said it a million times. I'm going to say it a million times more. Urine routine is a semi-quantitative test for urine protein. The reason is the urine pH and the specific gravity changes the protein reading. So if you have got an acidic pH, you will have a protein reading which is lower. If you have an alkaline pH, the protein reading is higher. Similarly, if your specific gravity is low, for example, in dysplastic kidneys, they have dilute urine, they are polyuric, you will never pick up proteinuria. And take it from me, they have nephrotic range proteinuria. And they have absent or trace protein in the urine. So if your specific gravity is low, your protein reading is low. If your specific gravity is high, protein reading becomes high. And therefore, it is not the best test. So the significant proteinuria on a urine protein creatinine ratio is what we should be looking for. The normal ratio is 0.2. Anything more than 1 is significantly abnormal and damages the kidneys.
So, Pankaj, suffices to say that a trace report of protein on a urine routine does not rule out nephrotic syndrome. You need to do the urinary protein creatinine ratio always to know whether there is significant proteinuria.
Yes. I think the answer to your question, Nitin, is I think people will never miss nephrotic syndrome. It is the other conditions that I'm worried about, because nephrotic is going to bloat up. You're going to do the blood test and you're going to find out. The more problematic ones are, for example, dysplastic kidneys, where there is nephrotic range proteinuria, but they have no symptoms. So you're never going to pick it up unless you ask for it.
Correct.
Right. Similarly, what is a significant WBC?
Okay. So I'm glad you said WBC and not pus cells. We need to change the nomenclature. So significant amount of white blood cells or leukocytes in the urine is defined as more than 5 per high power field in a centrifuged urine sample, or more than 10 per cubic millimeter in an uncentrifuged urine sample. Having said that, please let us understand that it is not equal to a urine infection. Leukocytes in the urine are not pathognomonic of a urine infection. You get it in many conditions, including fever itself can cause it, dehydration can cause it, inflammation anywhere else in the body can cause it. I had a girl who had proven appendicitis, surgery done, removed, at 150 pus cells in the urine. She never had a urine infection. You can have it secondary to calculi, to hypercalciuria, to any kind of nephritis, including your glomerulonephritis and interstitial nephritis. So there are many reasons why you get pus cells into inverted commas in the urine, and it is not pathognomonic of a urine infection.
Similarly, what about asymptomatic pyuria?
So asymptomatic pyuria is actually a catch-22 situation. You shouldn't be doing a urine sample in that patient anyway. So when we say asymptomatic, the child has no symptoms. So we have done a urine test.
The question comes, the child has no fever, no symptom, but someone has done a urine routine. Now it shows packed field of pus cell, and then they are worried, and people treat it. So that's the reason why this question as to what do you do?
So ideally, when we talk about urine infections, I will tell you where we have been going wrong. And when I say we, it is pediatric nephrologists, because we have been giving you wrong advice over the years. So we'll come to that. So asymptomatic pyuria means the child has absolutely no symptoms, but you're seeing pus cells in the urine. So only monitor the child. You don't need to treat it.
Perfect.
Now about RBC, Pankaj. What is significant RBC?
So for RBCs, what you mean is hematuria. I think we need to understand what is not hematuria before we even go to RBCs. Because many parents come to you, or you see some reports of urine routine when you have done test for nephrotic syndrome or something else, occult blood 2+ positive, 3+ positive, that has no significance whatsoever if the urine is clear. The occult blood is dependent on the pseudoperoxidase reaction of heme. So very few RBCs which have lysed can also give it positive, because it's a very sensitive chromogen. So occult blood positive is not hematuria. And I'll just mention 3 points that you need to remember. But before that, what is significant hematuria? When you've got red urine with plenty of RBCs, that is gross hematuria. What we are interested in knowing is if there is persistent microscopic hematuria. For that, you need to have more than 5 RBCs per high power field taken in 2 or 3 samples 2 or 3 weeks apart. Because very often in a cough and cold, today morning itself, somebody called me saying hepatitis A infection, RBCs in the urine. Accept it. When you repeat it, if the infection has gone away and the hematuria persists, that is persistent microscopic hematuria. Now, 3 important things just for you to remember. If the urine looks clear, occult blood is positive, it has no significance. Even in adults where they are worried about prostate, this is called a pseudo hematuria and they don't look at it. If you have got red urine with plenty of RBCs, it is gross hematuria. But if you have got red urine with no RBCs and occult blood positive, that is significant because that is hemoglobinuria or myoglobin.
Perfect, perfect.
So,
Now
the questions come that whether the patient goes to Pankaj when there is packed field of RBCs or comes to me when there are no RBCs with 4 plus blood, that because that is very likely to be acute immune hemolytic anemia or any of such disorder.
Hemoglobinuria, yeah.
Go ahead, go ahead.
Now, Pankaj, senior pediatricians, they are at times baffled about the nitrites test as well as leukoestrus because it was not there previously.
Correct.
So can you throw some light on these particular tests?
Well, the light that I may throw may not be in conformity with the guidelines and most of the other things that people say. So remember, nitrite test is testing for organisms that convert nitrate to nitrite. And that's all the test is telling you. So the specificity of this test with leukocytes and nitrite is supposed to be very high, 97%. Take it with a pinch of salt. The reason being, what is this being tested against? A positive urine culture. A positive urine culture is not always a urine infection. And that we'll talk about some other time. But that's one thing you need to remember. The second thing is, when you have got this dipstick, if you are going to do it in the clinic yourself, it makes sense. As I said, if you take it and you send it to the lab, it has no sense whatsoever. You will get nitrites positive in most patients because the urine. So there are false positives. 3 important things to remember. 1, if you have sent the sample and it has been checked after 1 hour, there is growth of contaminant organisms. You are very likely going to get it positive. So that's not an infection. So if freshly voided urine sample, if it is being positive, then it's fine.
So
But
that
even
means
if
I understand clearly that if you have a patient in the ward or in your OPD and you have a dipstick, you ask the patient to pass urine in a tube and you do it yourself, or sister does it within 5 minutes. If the nitrates come positive, that is more significant than on a urine sample which is left standing for more than an hour.
Yes, but there is a caveat to it. The second point is, if now you have got the dipstick in your clinic bottle, but you keep on opening it and take a stick out and then go and check it and then come and close the bottle. If you keep on leaving it exposed to air, within about 2 weeks, 50% of the sticks will start reading positive.
Correct.
So, keeping a bottle also, you need to follow the protocol of how you're going to check it.
So do you recommend for a common pediatrician to test in office such type of samples?
I think if you are more important than that, how many of the pediatricians have actually collected a urine sample?
Correct.
So if you tell the parent to collect a urine sample, now these are more important in infants. Right. Infant does not pass urine in your clinic. So the parents are sitting outside. Would you want parents to sit outside for 2 more hours? Correct. So the choice is yours.
No, so it is also that not all UTI suspects are infants. So there are some who are 1.5, 2 years who may oblige you by passing urine. So the idea is that if you are going to interpret, it should be on a fresh sample.
Correct. But in older children, then the symptoms come into play. No.
Correct.
It's the fever without focus area where we are worried about urine infections being missed, and that's why. So infants don't pass urine immediately. So if you have the stick in the clinic, well and good. If you don't have it, you're not missing much.
Similarly, many times few bacteria are seen, as such type of reports are there. So the significance of bacteria as well.
Again, the same thing. You've asked the patient to collect urine at 6 o'clock. He's put it in his pocket and he's brought it at 9 o'clock, and then it has been checked. So if the bacteria are seen in a child who's otherwise well, and there is no inflammatory marker like pus cells or anything, I would be very careful of interpreting it as urine infection. It's very often not.
Can you refrigerate the urine sample, Pankaj? to prevent all these mishaps of
Yes,
overflow.
ideally
Because
you
there's
should,
going to be
but
half an hour delay. Refrigerate it before taking it out and going to the lab.
that works for culture.
Yes,
Whereas for routine, we are not entirely sure how much it will work.
correct.
So there is something that you need to be careful about. But in a symptomatic child, if you see bacteria, so even one bacteria per oil immersion field, yes, it is significant. But most of the things that you are seeing in your clinic, bacteria positive on a urine routine report, is not significant.
Perfect.
Okay. So practically bacteria should not be taken seriously as per you. Now
Unless
before
the
going
child has symptoms. Yeah.
yes. Now before going to Sushmita, can you tell last about urine osmolarity?
Yes, I mentioned urine osmolarity right in the beginning also. So urine osmolarity is telling you about the ability of the kidneys to concentrate urine.
Perfect.
So there may be some pediatricians from Kutch who are listening to this talk. So you drink 3 liters of urine, you pee 500 ml. The same pediatrician now goes to a European country where it's cold. He drinks 2 liters and he passes 1.5 liters of urine. Now, this difference is made by the kidneys. So the kidneys decide how much urine to put out. And the ability of the kidneys to concentrate urine is measured in terms of osmolarity. Osmolarity and osmolality are different, though we use it interchangeably. Osmolarity is particles per liter. Osmolality is particles per kilogram. Now, it is important to know the osmolarity in certain cases, like, for example, if you've got a child who's polyuric, the history is of polyuria, then you want to know whether there is a concentrating defect. So, diabetes insipidus. So, early morning urine osmolarity may help you. Now, the normal range which is given there in the report has no meaning whatsoever. It's just like I explained for renal tubular acidosis. It depends on what the child is doing. So if you have got a serum osmolarity which is high, so normal 275, 285, so if your serum osmolarity is 295, then your urine osmolarity should be very high. So having a osmolarity of 300, which is the normal range, 350, is not normal. So it depends on what the serum osmolarity is. In other words, how concentrated the blood is. In other words, how dehydrated the child is.
Perfect.
Okay.
I think this was a very important thing because urine routine is one test that a pediatrician will ask day in and day out. And if they don't know how to interpret these basic tests, and you can see so many nuances were there, then it makes futile to even ask for the test. So good that we have recapitulated on various aspects of the urine routine report. Now let's go to the second common lab that we do, and that is urine culture. A lot of confusion about urine culture. Dr. Sushmita, again, a morning sample or any sample will do. Child is fever in the
So,
evening in your clinic, you can't make them wait till morning, correct?
yes, because if you have a very high suspicion of a UTI, you don't want to wait to send the urine and then start antibiotics. There is
Correct.
really nothing in the literature that tells you that a morning urine is required. I think one of the explanations that we often see is that the morning urine will be more concentrated and therefore bacteria are more likely to grow. But that there is really no hard evidence behind that.
Perfect.
And also we want to take the urine also at a time when we can, as the discussion previously, we want to get the urine sample to the lab as quickly as possible, even
Correct.
for our culture. So
So
I
that's
think it is
my
much better.
next question. That is it not good to tell the patient to go to the hospital where the culture is to be done or a lab and make them
It
wait there and
depends.
collect the urine rather
It
than
depends on the child, Dr. Nitin. If it is a toilet-trained child that you can take to the hospital and you can do local cleansing and collect a midstream sample, then that is fine. But often if you have an infant, where, as Pankaj was mentioning, that you often have to wait 1 or 2 hours, you have to expose, you have to clean, you have to give the child some drinks, you might have to stimulate the suprapubic area a little. So you have to do all this to get a proper midstream urine sample, then it may not be very feasible in the hospital setting. So in
okay.
that case, you would need them explain this whole process to them and ask them to collect it at home and bring it to the hospital or the lab as quickly as possible.
So again, the next question: you have collected the urine. I mean, the parents have collected. How fast it should be processed in the lab, and if it's not processed
So
for some
yeah.
reason immediately, can it be refrigerated or should be refrigerated?
So if you're the example you gave, that the child is getting symptoms and we don't want to wait overnight to start antibiotics, so that is the only kind of situation where we should resort to what is said is we can store the urine sample in a sterile container in the fridge at 4 degrees centigrade for up to 24 hours. But again, it is always better to get it to the lab if possible as soon as
Yeah, but the
we
question is,
can.
the parents may go to the lab, but the lab may actually sit on the sample because they are going to send it to some other higher center. So what
So
can be the,
I
how much
always
time
tell
can elapse
people,
between collection and putting in the culture media?
ideally it should be within 2 hours.
Correct.
It
All
should
right.
be plated within 2 hours. But
All right.
I often one thing is that sometimes patients will go to labs that have a tie-up with a higher center.
Correct.
I always tell them for urine cultures, it is better to go to a lab which processes the sample locally.
Exactly.
Otherwise, you take the child and stay in a relative's house in the city, which is close to the bigger labs, and do it that way. But
Perfect.
don't, bring the sample from a remote area overnight or, for traveling for 12 hours, because you will not get a relevant report that way.
Okay, now the critical question, which samples? So there are different ways you can collect sample for urine culture. The easiest will be midstream. So tell, how do you prepare local parts? What is midstream and how much volume?
So, simple cleansing with soap and water is required. I often tell the parents to collect it after a bath because then automatically the part is well cleaned. I will tell girls to ask girls to squat on the floor so that the thighs are abducted and the urine does not touch the skin, so the chance of contamination is less. Um, the contamination is what we are worried about. So that's one more reason not to collect the early morning urine because small infants are often in diapers overnight.
Correct.
And the chance of contamination is more. So
Perfect.
again, this is another reason why we should not collect the first morning urine in infants in diapers. So that is for cleansing. We should collect once the stream has started. We should take the container into the stream and pass it out again,
Correct.
so that we have the midstream urine. And
And
then, of
how,
course, yeah.
and
Sorry.
few ml is okay. You don't need
No,
more.
well, ideally 10 to 20 ml would be required.
Correct. So 10 to 20 ml is possible in older child, very easily. In an infant, sometimes they have to struggle, but that's the way it should be. Okay,
The other methods.
many
The
times the
other
question
methods.
comes that the
Yeah.
child, I mean, I try to collect, I wait, and by the time I little mood and the child is passed out. Now I have to wait for another 2, 3 hours. Doctor, is there any other way? Can we send for suprapubic? Can we send for CIC? Can we
So
do
before all
anything
that,
else?
I would like to mention the adhesive bags that are often used in the hospitals. Those are valuable if you get a negative report. So if it is sterile, but if it is positive, then you
Correct.
cannot trust them because you do not know if they are contaminated.
Correct. So
Then you have
collection
to
from a
repeat.
urinary bag is best avoided.
Best
Collecting
avoided.
from a diaper or from a
Is
plastic sheet, all are
absolutely
completely
no.
not to be done.
Absolute
Correct.
no.
But the other methods,
Regarding the suprapubic aspirate or a catheter sample, we often resort to that in a sick child, especially a small child who is not toilet
correct.
trained, because we want to start off because it's a critically ill child. We want the sample in as clean and sterile a way as possible, and we want to start off the antibiotics as soon as possible.
Okay. You
So,
think suprapubic is easy to do by resident or by
I
reasonably
don't
trained
think
resident?
I don't think people should try for suprapubic unless they're very used to doing it, unless they have an ultrasound machine handy to check that the bladder is full. I think the simplest way to get an urgent urine sample is by catheterization under sterile conditions.
So one question that is often asked is that if you use soap and water to clean the area, if the soap remains there, the culture may not grow. So is it okay to just clean with water, or you always use soap water? And if you're using soap, then you see that you pour a lot of water to wash up the soap before you collect the
Yes,
urine.
just wash very well.
Correct. All right. What about the CIC?
Do you mean
A
CIC
catheter
is something?
sample?
So catheter sample, yes. Catheter sample, I mentioned suprapubic versus catheter sample. I think for untrained pediatricians or pediatricians in the peripheries who do not have access to ultrasound machine, I think the easiest in a sick, non-toilet trained child is a catheter sample.
Catheter. Okay. Now, a report comes back. At what colony count is it significant? Is it sacrosanct for all, or it's only for E. coli? And also based on what sample? Like in a suprapubic, even if any colony is significant vis-a-vis a midstream. So how does one interpret?
So the numbers of bacteria that you take as significant is a little bit different according to the method that you have used, and this
Correct.
all depends on the chance of contamination.
Correct.
So a suprapubic has got least chance of contamination, and there really any growth is significant. Any growth, the minimum growth that is usually detected on a culture is 10 to the power of 3 per ml. So 10 to the power of 3 per ml, which is the minimum growth, is taken as positive from a suprapubic aspirate.
Okay.
It has to be a single. It has to be a single. Whatever method you are doing, it has to be a single organism.
Okay.
For
Midstream.
next is coming to the culture. Culture we take as we consider 10 to the power of 4 colony forming units per ml. And for midstream, all along we were saying 10 to the power of 5. But if you look at the recent guidelines, it says 10 to the power of 4 to 10 to the power of 5, depending on what the symptoms are. So if you have a small child with very significant symptoms of UTI, then you can also take the 10 to the power of 4 per ml as a diagnosis of UTI.
And the previous antibiotic used before collecting culture, would it make a difference in the interpretation of the colony count?
Definitely, definitely.
So like
ideally,
ideally he has to collect before antibiotic, but it is not always your fault. Patient is already on a correct antibiotic and now he comes
if you
in.
if you have a high index of suspicion and the child is already on antibiotics and you do not grow anything significant
No, not
on
grow.
culture,
You grow say 10 to 2
grow,
or
but
10
not
to 3.
you have to go by your clinical assumption, your clinical symptoms, and take that. Will you take it as seriously or not? So
and you mentioned it should be a single growth like E. coli, whatever. If a multiple organism, what does it mean?
Usually a contamination.
Usually a contamination. All right, last question. Many times, like we'll come to the case also that the patient has been started on an antibiotic following culture sample given, and the report comes after say 48 hours or 72 hours. It shows that the sensitivity is not there for the given antibiotic, but the patient is better.
So
Is
again,
that something to do with the urinary
evidence,
MIC vis-a-vis
the
the blood
evidence is
MICs?
fairly clear that if the clinical response is what you're looking at, in vivo, in vitro, there might be a difference. If there is clinical response, then you continue the same antibiotic.
Are there any labs doing urinary MIC for the commonly used antibiotics so that it's
So
a better indication?
we do get urinary MICs in many labs, but urinary MICs should not be compared between antibiotics. Because the dilutions that are available for these MICs often differ from antibiotic to antibiotic. So the dilutions available for one antibiotic maybe say maybe completely different. Say for co-amoxiclav, it is one dilution. For say ceftriaxone, it is completely some other dilution. So you cannot compare the dilution.
No. So can we say that the antibiotics which are concentrated in urinary system have a lower MIC in the urine than the blood, and actually that's the reason why the reports which are actually based on the blood culture, what do you call the breakup points actually do not reflect the urinary concentration. And that's the reason why there's discrepancy in the.
So it is the breakpoints of resistance are never given in the urinary reports.
Exactly.
And what is really the point to decide is that MIC, how much it differs, what is the difference between the MIC and the breakpoint of resistance. And the greater that difference, the stronger is the antibiotic is likely, the more the antibiotic is likely to work in that case.
Okay,
but I think what you said is very important, that we should look more at what the antibiotic is that has been put up for sensitivity. Does it concentrate in the renal system, in the urine, and only use an antibiotic that will concentrate in the urinary system for UTIs?
Fine. So we have some more labs which are commonly asked before we actually move to the cases. So maybe Dr. Ramesh, you can run it with Dr. Fagun quickly because we already have spent 35 minutes.
Yes, Fagun bhai. Crisp and clear. Now the common investigations: blood urea, nitrogen, and serum creatinine, and method of testing, please.
So basically, if you look at the renal
Fagun, a little louder, please.
Louder, Fagun bhai.
So if we look at the renal function test that we normally advise in the patients whom we are suspecting a kidney injury, the two things which comes to our mind is basically the blood urea nitrogen or the blood urea, and second important thing is the serum creatinine. So coming to the blood urea, as we all know, or as the name suggests, that it is the blood urea nitrogen. So it is from the nitrogenous waste products, that is the protein catabolism, formed in the liver and finally excreted in the kidney. So in the patients with the liver disorders, we might have an caveat in the interpreting of the BUN, which might be low. The second important point is that when you interpret a BUN, that there are two things which might confound the results. That is basically the hydration status, and second very important thing is the protein catabolism. So basically, if the protein catabolism is very high, or if the patients are very cachexic, in that instance, you might have changes in your blood urea levels. For example, the cachexic patients might have a low urea levels, or in the patients with the protein catabolic states, the urea levels might be high. Again, coming to the hydration status. So the urea level also depends upon how better is the hydration status. For example, even in the patients in which the kidney perfusion is less, that is, for example, in the patients with the nephrotic syndrome, or in the patients with the CCF, in which we have a less circulating volume and the kidneys are perfused less, there could be a high urea levels with a normal or slightly elevated creatinine levels. And as we all know, that in the patients with the dehydration, because of the reabsorption of the urea, we might have a high urea level. So we try to see what is the blood urea creatinine ratio, which we normally ask for, and if it is more than 20, it indicates that the patients are having a dehydration or a pre-renal component. And coming to the creatinine, I think we all know that it is the product of the muscle metabolism. So lower the muscle mass, lesser is the creatinine, higher the muscle mass, more is the creatinine. And as Dr. Pankaj rightly said, that many a times we have very cachexic infants or infants with severe failure to thrive, in whom even though the renal functions, or we can say the GFR is very low, but the creatinine doesn't show very high. In fact, the creatinine follows the GFR. So unless and until we have 50% of the GFR, or we can say more than 25% of the nephrons are damaged and the GFR falls to 50%, the creatinine will not start rising. And hence it is very, very imperative that in this patient, it is better.
So sorry to interrupt you, Vagun, but when you say there is a relation of creatinine is a reflection of GFR, while I understand that they may not going to manifest chronic renal failure, but the GFR will keep on falling, right? It is good to calculate creatinine clearance rather than only looking at the creatinine level in children, because at different age with different body size, as you very rightly said, the creatinine will be different, but the GFR has to be constant in most of your life, correct?
So that is what I'm coming to, that you need to calculate the GFR in all the patients in which you are suspecting a chronic kidney disease, especially the patients who are very, very cachexic. So here it's very easy to calculate by the simple Schwartz formula, which says that it is K, that is the constant, which is 0.43 into the height in centimeters and divided by the serum creatinine in milligrams per deciliter. So basically, initially
this is valid till what age, Dr. Fagun, or till what weight of the child? I mean, because adults use a different formula.
Yeah. So basically, we can easily do it in the children up to the 12 years of the age, or also in adolescents. But basically, initially we had the different K values, because what we were calculating the creatinine values were from the Jeffs method, which is basically an analytical method. But now what we are using is an enzymatic method, which is a more better method and gives a more better estimate of the creatinine. So only when you have the creatinine by the enzymatic method does the K constant of 0.43 can be applied to that.
Correct. Okay, fine.
Now, you said about calculating GFR. We all subject for serum electrolytes, but can you explain urinary electrolytes interpretation also along with serum electrolytes?
So interpreting, actually, I just had a message to Dr.
Can you be louder?
We
because
can't
your voice
hear.
seems to be muffled.
I think maybe if you remove your the earphones and just speak on the laptop if you are using, it might be easier. Yeah. Just see now. Say something.
Speak something.
You'll have to disconnect your earphones first, so that
I think he'll have to.
Am I audible now?
No, it's still not that great.
Yes.
Again, you wear it, but speak loudly. That's it. You wear your earphone and speak loudly. Fagun, not audible. Fagun?
We can't hear you, Fagun.
Fagun, we can't hear you.
Maybe till the time Fagun settles, maybe Pankaj, you can answer this question as to how do you I mean, people are very well known to do serum electrolyte, but urinary electrolyte is something which we keep on asking in sick patient. How to interpret that?
I think the most important thing you need to realize.
Hello, is it okay now?
Yeah,
Yes,
Fagun,
yes,
Fagun, okay,
yes.
Carry
Fagun,
on.
fine, perfect.
Yeah, so basically, I just also messaged Dr. Nitin Bhai in the morning that what are we going to talk, discuss regarding urinary electrolytes, because
No, so we
basically
don't want to
talking,
go into detail. Just
yeah,
explain that there's something known as urinary electrolytes and
yeah, so
what,
that's what
what,
I'm talking
where do you
about.
do it and what does, how does it help you?
Yeah. So basically, talking about urinary electrolytes is basically opening a Pandora's box, because most of the times we are, as far as the interpretation is concerned, and as far as advising urinary electrolytes are concerned. So when we talk about the urinary electrolytes, that is the sodium, potassium, or chloride, it has to be interpreted always along with the serum electrolytes and also with the blood gas. And most of the times you might also need to have a osmolarity, that is a urine and serum osmolarity along with you.
Correct.
And the most important thing here is this, that basically what you are looking when you are asking for a urinary electrolyte. So you are looking at an acid-base disorder or a fluid and electrolyte disorder. So in other words, what we can say is that we are looking at the renal tubular functions. So we don't have any absolute values, as Dr. Pankaj said, of all these electrolytes. So we have to interpret it in the context of whatever clinical condition we have. Say, for example, if the child is having a hypokalemia and if you are going to go for a urinary potassium, then you should know what you are looking for in the urinary potassium to say that the renal functions are optimum or not. Say, for example, if the potassium, if with hypokalemia, if your urinary potassium is high, it indicates we have a loss of the potassium in the urine, and likewise for the sodium. So basically, the point here is this, that when you're talking about the urinary electrolytes, you have to interpret it in the context of the clinical condition, as well as along with the serum electrolytes, and as well as along with your blood gases. And having said that, there are a lot of other electrolytes which also we need to see for, say, for example, urinary calcium or phosphorus, or we have the bicarbonate, etc., which we use it for various conditions like blood gas, etc. So urinary electrolytes is basically a very important thing which will help you or us to diagnose variety of the renal tubular conditions if it is advised at a proper time and interpreted in a right light.
Perfect. So I think now let's move to the
Otherwise,
cases.
otherwise,
Pankaj.
Otherwise, if you've got normal electrolytes and do urine electrolytes, you will only diagnose what they've eaten the previous day, McDonald's meal or Pizza Hut.
Very right. But I think urinary electrolytes are more important for sick patient in hospital. We're talking about salt waste, cerebral salt wasting, SIADH, and so many other renal injuries which are monitoring. I think that's where the interpretation comes more. But I just wanted that, let pediatricians know there's something known as urinary electrolytes besides serum electrolytes. I think we'll leave it there and let's move to the cases now.
Can I
Yeah.
just add a line? Dr. Nitin, can I just add a line here? Urinary
please.
sodium is one good test which differentiate between the pre-renal and the established renal failure, and it's something which can be done very easily.
Perfect.
At times we are stuck, and anybody can be stuck that whether it's still an incipient renal
I think we have lost Dr.
failure.
Vasudev. Vasudev, you can put off your video because your line is unstable.
Established one. So urinary sodium will be done. Thank you.
Yeah, okay, fine. Let's move to the cases now.
I was just saying that urinary sodium is quite a useful test.
Yeah. Okay. Let's move to the cases. First case, Dr. Sushmita. 20-year-old pregnant lady has undergone an antenatal scan for fetal anomalies, as is done now for most of the pregnancies. At 18 weeks of gestation, the anterior-posterior diameter of the left renal pelvis, that is the renal pelvis diameter, is reported as 10 millimeter. And she was told by the sonologist that you need to follow up these babies with the scan at the time of birth and tell your pediatrician that there was something wrong in the ultrasound, in the anomaly scan. She has now given birth to a male child, 3 kilos birth weight, otherwise healthy. So, first question, what is the cutoff for the renal pelvis diameter to necessitate further follow-up when done antenatally? Unmute yourself, Dr. Sushmita.
Hello. Okay,
Yeah.
now?
Yes,
so
please.
Your case says that there was only one scan done at 18 weeks.
That's right.
So that is a little bit unusual. That early, if you have 10 millimeter dilatation of the renal pelvis, that is quite significant. And this would in itself need follow-up during pregnancy, at least one more scan around 32 weeks or later to see if this is progressing or not.
Correct.
So
Suppose
in
it
the
has remained
second,
the same, or it
so
has
in the cutoffs in the second trimester are 7 millimeters, and in the third trimester are 10 millimeters.
correct,
So this was already 10 millimeters in the second
correct,
trimester, in the first,
correct,
in the second
correct,
trimester. So
correct.
this needed follow-up.
Okay.
After birth, after the first 48 hours, it is considered as 10 millimeters being the cutoff.
Correct.
But
So this child
even
already
there,
had the cutoff postnatally in the intranatal very early in life. So this
that's
is
right.
likely to be very
So
significant, correct?
this is something that needed, although many of these cases can be transient and many of them can just, get better even during pregnancy, but definitely a follow-up would be needed.
Correct.
Second
So
point,
how frequently would you do antenatal scan if you found in the first scan diameter of say 7 or above? How frequently you do before
so
the
at least
delivery?
one more at 32 weeks.
32 weeks.
If it is increasing, then more frequently. If it is the same, then not so frequently.
All right.
But just one more, Dr. Nitin, please, just one thing very important is that we are not only looking at pelvic dilatation. We should also be looking at, we should also make sure that the other kidney is completely normal, that there is no ureteric dilatation, that the bladder is filling and emptying properly, and the lighter volume.
Correct. This is the report which with the mother comes to you at the time of delivery.
Right, right.
Right. So now you have to
so
give them
it's
answer.
very late. Yeah.
So what is the incidence in general of this type of PUJ obstruction or UPJ obstruction, whatever way you call it?
So the incidence, it depends on what measurement you're taking and what time of pregnancy you're looking at.
No, in general, an established
It's a very,
PUJ
very
obstruction.
variable in the many reports depending on these factors, like when they do it and what measurements they
No, I'm not saying that.
And
I'm
it's
saying,
taken,
I'm
so
saying
I'm coming
what,
to figures.
What
I'm
is
coming
the
to figures.
incidence of an
It is
established PUJ obstruction? We are talking about
between,
when to diagnose, when to
So
label
between
someone.
0.6 and 5% is what has been reported. So it's quite a
0.6%
variation.
of the pregnancies have a PUJ obstruction suspected.
Yes.
And how many have actually ultimately proven to be significant?
So maybe about of all that are diagnosed, those that are diagnosed early on, 80% will resolve.
Okay.
And those that persist till later on in pregnancy, 50% will persist and need follow-up.
All right. Is there any sex predilection, like a male is more affected or a female?
Well, like everything else, males are more likely to have.
Okay, so this is disadvantage of being a male child. All right, again, predilection on the side, left versus right, or they're the same?
Strangely, right side is reported more, and apparently it's something to do with physiological dextrorotation of the gravid uterus, which causes compression against the pelvic brim of the fetus, and apparently that is the reason that the right side is more affected.
And can it be bilateral?
It can be bilateral, yes.
And in such case, you will be a little more aggressive because, as you said very rightly.
Because if it is bilateral, we must be sure that there is no lower urinary tract obstruction.
Correct.
So
like this is a male child.
Male child. So the commonest of which is posterior urethral valves.
And in a female?
And, in female, if it is bilateral, the next after the commonest condition that occurs is transient hydronephrosis. The second is UPJ obstruction. It may be unilateral or bilateral. Third most common is vesicouretric reflux, dilating. So the higher degrees of vesicouretric reflux that causes pelvic dilatation. And if it is, that can also be unilateral or bilateral.
But when you say PUJ obstruction, by definition, it would mean that the ureters are normal, right?
No, the upper ureter, where it joins us with the pelvis, over there is a constriction.
Correct.
But on ultrasound, the ureters are normal. Yes, they are not dilated.
If the ureters are abnormal, then it's not PUJ obstruction. It is some other cause of hydronephrosis. That's the different thing, right?
Yes.
Correct. All right. So, what causes this pure UPJ obstruction or the PUJ? I think pediatricians are more tuned to PUJ obstruction. I don't know why suddenly books mention as UPJ obstruction. So anyway, whatever, pelvic junction obstruction.
It is considered as a developmental anomaly, some kind of dysplasia of the upper ureter where it joins with the pelvis. The exact cause is unknown.
So can there be also some aberrant artery or
sometimes you can have obstruction, but then that's not an intrinsic obstruction. That is not the common one. You can have an aberrant artery which is compressing, but that's a much rarer cause.
All right. So how will, I mean, this is okay here, the mother underwent an antenatal diagnosis. Suppose there's a baby born and no antenatal scan was done, which is true for so many deliveries. How will an infant who actually has a significant PUJ obstruction present in early infancy?
So the child would only present if there was a significant obstruction causing a mass, causing a hydronephrotic mass. So then we might be able to palpate a lump.
Correct.
If it is a boy and the hydronephrosis is bilateral and due to posterior urethral valves, then you might
No,
get.
I'm not talking about.
You're
I'm
not
not talking
talking
about
about
hydronephrosis.
that.
I'm talking only pure PUJ obstruction. This child has a PUJ obstruction.
So you
How
might
will
not. It might be totally quiet. You might not be able to pick it up at all.
will it come as UTI in an infant?
There is a higher incidence of UTI, but it is nowhere as high as children who have vesicoureteral reflux or PUV or
Okay,
anything
understood.
like that.
And suppose this child is beyond infancy, like 2 year, 3 year, and he can be a miss
Again, it
PUJ.
can
How
be
will it present?
It can present with a lump, can present with pain, because sometimes the lumps are so big that there is a little bit of torsion. So then you can get episodic pain. There may be stones within the hydronephrotic element.
Correct.
There might be hematuria episodically. So these are the different
And what
types
is
of
this
presentation.
diuretic crisis? They say they like some fizz drink, color drink, a lot of fluid suddenly, and then they get sudden pain because the pressure become more.
So that is So if there is sudden expansion of the pelvis, then there can be episodic pain.
All right. So let's coming back to our case. We discussed in general PGR. Let's come to our case. Now this child was having antenatal scan showing 10 millimeter, which itself was very significant. Now when will you do the first postnatal scan after birth? Within 48 hours, after 40 to 70 hours, and why?
So if it is unilateral hydronephrosis, then we would prefer to do the scan after 48 hours.
Okay.
But within the first week, preferably before the child goes home. But nowadays, children go home very early, the second, third day. So in that case, we might have to plan for the follow-up ultrasound.
Perfect.
Just after 48 hours, maybe, because it's always preferable to do it before you send the child home.
And you already said that.
And the reason we don't want to do it very early is because that the first 48 hours is a state of semi-dehydration in the child. So if the child is not well hydrated, the dilatation of the may not be seen on ultrasound.
Perfect. So now you already said that on ultrasound, if you see bilateral, you see hydroureter, you see gross hydronephrosis, then you think of not PUJ but PUVAL, reflux, etc. So that is point well taken. Now the question comes postnatally. How do you manage this children? Is it based on the epidiameter you find on your first postnatal ultrasound? And if so, at what cutoff for different approaches, like 15 millimeter, 30 millimeters, between 15 and 30? Does your management change?
So first of all, it is a dynamic process, this obstruction. So if there is real obstruction, things will keep getting worse. If we do have classifications that go by diameter, but I think the best classification that is available to us nowadays is called the UTD classification. Urinary tract dilatation classification, which gives us the antenatal classification and the postnatal classification. So it tells you antenatally, if you find this and this, you do this and this postnatally, and you follow up like this. So I think that is the best form.
So now
best classification.
So let me give. Okay, let me give you 3 scenarios. This child postnatal sonography done at 72 hours shows a RPD which is more than 10 but below less than 15. Now what do? You follow him up how frequently?
So 10 to 15 is what is called P1. So it is low risk at that time. But we would usually do, because we've done this fairly early within the 1 week usually. So usually we would do a follow-up at 1 month to make sure that there is no major increase. And then every 3 to 4 months, or if it is remaining very stable, every 6 months.
Okay.
So
and if
again,
it is
it's
increasing,
a dynamic. If it is increasing, then we need to go ahead and do further tests, because every time if it is increasing, then our alarm bells should go off that there is a real obstruction here.
So to start with, suppose you found that it was 25 millimeters on your first 48-hour scan. Now, does it change your management plan? You just still keep them on following, or now you'll do a EC scan?
Yes, so if it is 25 millimeters, that is pretty significant.
Mhm.
Again, we are going to look at is there are the calyces also dilated, not just the
Mhm.
pelvis, calyces also dilated, is the parenchyma getting compressed?
Mhm.
And that kind of a condition, we would do a EC scan in the
So
early
what is the
stages.
EC scan vis-a-vis, say, DMSA, DTPA that people are aware? What is this EC scan different from the other renal scans?
The EC scan, the DMSA is not appropriate here because DMSA is something that is taken up in the tubules and stored in the tubules.
No, I
where
know that.
we
I'm
look
just
at
saying people
cortical
are,
function.
the
But
pediatricians
EC
have heard
between
these names. So what is the
so the
differences in
the choice is between MAG3, EC, and DTPA here. MAG3 in our country, it is very expensive and not available
Mhm.
in most places. So we
Mhm.
leave MAG3 out of it. Now, if we compare EC to DTPA, the advantage of EC is that it is taken up even in immature kidneys with a lower GFR.
Mhm.
So in a neonate, where the uptake may be less because of lower GFR, because of a relatively dehydrated state, we prefer a EC scan. In an older child, we could also do a DTPA scan.
So what is the EC scan? What exactly is done? It's a
It's
diuretic
very
scan.
it's very similar to the DTPA scan. So you get an isotope injected, and then you get then the child is put under a gamma ray, and the radiation from the isotope passing through the body is picked up by the gamma camera.
Mhm.
And what you get is you get graphs where initially you see the perfusion in the kidneys. So the isotope is moving through the blood vessels and into the renal artery. Then
Mhm.
you and perfusing the kidney. Then the isotope gets excreted from the kidney. So
Correct.
you get an upgoing curve where it is getting concentrated in the kidney, and then you get a downgoing curve where when the renal area is focused on, so the isotope is moving out of the kidney. And
So what
there,
would
if
an
there is,
abnormal EC scan would mean? Like what?
so
Delayed
if there is an
emptying or?
obstruction,
Mhm.
then instead of coming down, that curve would keep going up, and
Okay.
there would be incomplete excretion after even up to 20 minutes.
Okay.
So that
So
could be an indication of, and so yeah, that would give an indication that there is an obstruction on that side.
okay. So the last 2 or 3 questions on such a patient. Do you have decided to conserve your EC scan shows that the renal function on both sides is good, 60-40, 50-50. You're not worried about damage to the affected kidney. You put them on antibiotic prophylaxis
So just
first
to
on, or
interrupt,
if you only get a UTI.
sorry, Antenatal, just to
Ah.
interrupt. 50-50 is normal, but 60-40 is not normal.
Yeah, but 60-40 is acceptable.
No. So if there is 10 to 20% reduction, then
Mhm.
it means that the kidneys are getting compromised. So
Mhm.
it should be 50-50 on both sides, right?
Mhm.
If it is 40-60, that means there is 10% reduction on that side.
Mhm.
So
So
that is a
10% would
worry.
mean send them
That
for
is a
surgery.
worry. Not necessarily.
Yeah.
Again, everything has its fallacies, but you have to tie everything up together. If there is increasing pelvic dilatation, if there is obstruction on the EC scan or the DTPA scan, if there is reducing function, so all this whole picture has to be put together. And if they're all suggesting obstruction, then you go for surgery.
Okay. And what about antibiotic prophylaxis till the surgery is planned or is?
So if there is no BUR, if there is no history of UTIs, then currently the evidence is that we don't need surgery in PUG obstruction alone.
And if
If
there
we do
was
not
one,
need we do not need antibiotics
and if there was
in
one
PUG
UTI in the
obstruction.
past, now till the time you follow up and you decide on surgery or
If
not.
there is one UTI, then again case-based, I think you would have to look, is there is concomitant reflux over
Mhm.
there? If there
Mhm.
is concomitant reflux, then certainly you would, if high-grade reflux, then you would want to
All right. And you
start.
follow up these people what for life? Till if suppose they are not fitting into required surgery, so how long you follow up with ultrasound and
It depends. It depends on the grade. If it is a very minor grade, then yes, you would. But you would, increase the gap between
okay.
follow-up
So annually.
gradually.
Mhm.
Annually to yearly. If it is say just 10 millimeters or something, then yeah,
Okay.
yearly, 3 yearly.
What happens to these babies if they are operated or if they are not operated? In long run, they are all okay, or they have some compromised renal function as an adult?
If they are operated, the kidney, that is the one example you gave, that had become 60-40, it may or may not regain that function,
Right.
especially if it was congenitally, the issue congenitally, but they should ideally not be any worsening.
Okay. I think we have discussed at great length, and I think the message that I want to give is that an Antenatal scan is must for every child. Look at the RPD. If the RPD is above 7 millimeter in the first trimester or second trimester, definitely merits one more before the delivery. And if any time it reaches more than 7 to 10, a postnatal scan, and if it shows an increasing dilatation, these are the children who will need an EC scan to see for the differential function. And if they are going to develop UTI, treat them well so that they don't get renal damage. And the decision to operate or not to operate is best left to the specialist. The pediatrician role is that they should understand and take part with the nephrologist to see that the children are well managed for their immunization, for everything else, treated not haphazardly with antibiotic for every fever without a urine routine and a urine culture, and so on and so forth. And let the specialist decide which are the ones who are likely to go for surgery. Last point, Pankaj, you raise your hand.
Yeah.
Yes.
Just 2 points more for pediatricians. Don't quote me on this. This is a very, very old study, just for you to be aware.
You are
that
already on, you are quoting yourselves.
I know. But if your AP diameter, so just to give you an idea of who needs surgery, if your AP
Correct.
diameter is more than 50 millimeters, 100% children need surgery.
Correct.
If it is 40, around 80% need surgery. If it is 30, 60% need surgery. And if your AP diameter is 20 or less, only 20% need surgery. As Sushmita said, 80% don't need surgery. They get better on their own.
Correct.
So
So
there's a
the surgery would depend on a worsening AP diameter
worsening
and
diameter
worsening EC
functioning of
scan.
the EC scan. The second
Okay.
point which I want to say, which is very often what happens, is the nuclear medicine scan should not be done too early.
Correct.
As she said, the
4
immature
months.
nephrons. No. So DTPA, please do not do it before 3 months of age.
Correct.
EC scan, earliest you can do is 6 weeks.
Correct.
Max 6 weeks. EC scan is actually 8 to 10 weeks, not 6 weeks, because you will not be able to interpret it. That's the problem. Yeah.
Perfect. I think we have discussed enough on this. We have sensitized the pediatrician to pick up one and refer. Next case, Dr. Ramesh, please take with Dr. Pankaj.
Yes. So, Pankaj bhai, will be crisp and clear because now we have got less time. And Nitin bhai has prepared questions in a way that you will be able to answer it fast. So 6 months male child presented with high-grade fever, though feeding well but irritable since last 3 days. There is no focus, absolutely. No sick contact, passes urine well. On examination, child is looking sick. Interfontanal is normal. CRT is less than 3 seconds. There is phimosis. And per abdomen examination is normal. Systemic examination is normal. Child has been treated with PCM. But fever continues, so oral amoxicillin add. Now, after adding amoxicillin, which are your thoughts? What is wrong here?
So I'm going to take 5 minutes here because I want to point out something else.
Yeah,
I think this, if you throw to all pediatricians, they all know what is wrong here. I'm going to point out something else. And just before I start, since you are asking me the questions, I'm going to repeat, I'm going to ask you questions. It's very interesting that Nitin bhai selected a child who had fever without focus and not with urinary symptoms. So my question to you is, out of all children having fever without focus, how many turn out to have UTIs? What guess? Take a guess.
Depends on at what age.
No, I'm asking Dr. Ramesh bhai.
Okay.
Let's see.
No, at least I get each and every child urine examination done.
No, I'm asking you a very different question. I'm asking you, what does literature say as to how many of these children actually turn out to have UTIs?
In my practice, I have seen 20%, around 20%.
Right. So the literature that you find, or all the studies that have focused, is it used to be between 9 to 12%. Now, with more robust criteria of UTI, it's come down to 5 to 7%. Do you understand what it means? It means that 95% of children do not have UTIs. Let's look at the other way around. So I think the problem here is a pediatrician's thinking or a doctor's thinking is, child has come having fever without focus, let me rule out a UTI by doing a urine test. Unfortunately, that doesn't work in your favor, because we started right off by saying pyuria can be seen in patients who have fever or any other focus of infection also. And that's where things start going wrong. I think the problem here is that we haven't started differentiating. Forget Dr. Deshpande is mad. He doesn't know what he talks about. But let's go back to the guidelines. We have got American guidelines, which we are fond of quoting everywhere. Even before they reach UTI, do you know what they say about children presenting having fever without focus? The ultimate statement is that if you have a child having fever without focus but is well, it is reasonable to follow up the child without doing a urine test till the fever disappears or till you decide to do a urine test.
Absolutely.
And
But
how
if a
do they
sick
decide?
child,
No,
but
no,
if it's a sick child.
no. So that's why the only key word that you have used there is sick child. I'll come to that. That's why I wanted to point this out. Unfortunately, children are not this clean when they come to your clinic. Most of the children you see will be well children, and that's the difference between the two. So I think what even they used is they are saying there have been criteria that have been used in the past to decide who to send a urine sample in. Gorlick's criteria, for example, they said more than 39 race, depending previous urinary anomalies that are present. In those, you send urine test. Otherwise, don't send urine test because you will just confound yourself, getting results which you cannot interpret. So the problem here, I actually have an algorithm. I'll come back and talk to you about that algorithm which I have published about what to do in these children, what we need to differentiate. The second bigger problem is that it has been taught or imprinted on everybody's mind that there is this Big Bang theory, that if you don't treat a urine infection immediately, the child is going to die. It's as simple as that. It doesn't work that way. There is a Greek study which has looked at patients who were treated with antibiotics. The median time of treating was 2 days. There were children who were treated on the first day of fever and children who were treated after 4 days, the 5th day, and the long-term outcome remained the same. So I think what we need to understand is, if it is what we need to do is we need to differentiate between a well child and a sick child. If a sick child presents to you, send a urine sample off immediately. There is no question about it. Which method you use, that's a different matter, but send a urine sample. If it is a well child who comes to the clinic, who's happily playing, you are entitled to wait for a few days. If I ask the audience here, when do you send a urine sample in a child who presents to you having fever without focus, I can guarantee you that there will be different answers. Some will say 24 hours, some will say 48 hours, some will say 72 hours. And then we are trying to say all are uniform. That's not uniformity. We ourselves are creating models for ourselves. So I think
Pankaj, the standard care is that if you have a well child feeding well, just fever without focus, you can wait for 40 to 72 hours before you think of investigating.
Correct.
But a sick child, even on day one, you should not wait. That's the question.
That's exactly what I'm saying.
Yes.
So if you have got a sick child, send a urine sample off and you have to treat with antibiotics.
Okay.
Whereas if you have a well child, you can wait and follow up the child to find out if the fever goes away. So in this case, I don't think the pediatrician was wrong initially if he didn't do a urine test, if the child was well. If the child became sick and he sent a urine sample at that time, he was justified. Unfortunately,
no, but he didn't send urine sample. He started antibiotic.
Exactly. That is the problem. So the mistake here is not that he didn't send a urine sample in the beginning. He started antibiotics without sending the urine sample.
Okay.
Yes.
Let's come to the investigations.
So now the reports are hemoglobin 9 gram%, WBC 24,000, polymorph 68, lymphocyte 32, platelets are 3.5 lakhs. CRP was very high, 120. Urine routine showed protein trace, RBCs 5 to 6 per high power feed, WBC packed feed, no cause, few bacteria seen, and nitrites was positive. So now thoughts?
I think everybody knows it's a urine infection. We can go faster on this.
Yes.
So the interpretation of urine analysis, I mean nitrites versus esterase.
We already talked about it.
Okay.
Yeah.
Now what next? How to collect urine cultures?
We also collect.
We have talked about, but just to point out, there was a very beautiful study that was done in all patients who presented having symptoms of urinary tract infection. They collected a midstream urine, a bag urine, a suprapubic, and a catheter sample. And I can tell you that in the bag urine, whatever cultures came positive, none of them had a urine infection. In those children who had midstream urine collected, only 30 to 40% actually had a urine infection on suprapubic.
Oh,
so be careful.
So now
no, but that doesn't mean that you don't. I mean, you take a midstream urine and you see a growth. You ignore in a symptomatic child.
No, what I'm trying to say is again, go back to the American guidelines. If you actually read them before you reach the UTI section, infants, forget about older children, infants, 0.7% of infants have a positive urine culture done 3 times at different occasions.
But
Who are
symptomatic.
completely asymptomatic.
No, we are talking about symptomatic child.
I know.
So
I'm
I
just
think we have
talking
to, yeah. So I
Yeah.
understand. We discussed that asymptomatic bacteria. Why would you even do a urine culture in a child who has no fever?
Correct. No,
So I
but
think that is the message. The
but
message is
if you have a fever due to a viral infection, these children will still have a positive urine culture.
correct, but
And
you
that's
are
what
not going.
happened. Not
Correct.
this child. I'm generally saying. Yeah.
So now, Pankaj, till culture reports come, which is the choice of antibiotic and
Yeah.
dose, route, and
So
administration according to
so the guidelines say amoxiclav or third generation cephalosporin. Cefixime is the common antibiotic that is used. We prefer oral antibiotics. IV is to be used if the child is not tolerating oral, if the child is very sick or is less than 2 months of age.
Correct.
Okay, so here patient was put on oral cefixime 10 mg per kg per day in 2 divided doses, as we all know. Now baby is improving, fever subsides, feeds well now, no irritability, but now culture report comes and it shows E. coli more than 10 raised to 5 colony counts, resistant to cefixime. So should we continue now cefixime or should change antibiotics?
Continue cefixime, as was discussed earlier. The in vitro, in vivo sensitivities are different. So clinical response is what we go by. We don't go by what the sensitivities are.
Correct.
Okay. Now, how do you monitor? By repeating urine routine or
No.
culture?
Neither urine routine nor culture are required. Clinical response is what you look for. If there has been a clinical response, you presume the urine infection has been treated.
Perfect. But now you have diagnosed UTI. So would you like to go for identifying the cause?
And unfortunately, when you ask this question, most pediatricians think about radiology. The answer is not radiology. Talk to the parents to find out the cause of the urine infection. The cause of urine infection is right in front of you. It's usually because the child is constipated. In this case, the child had phimosis. The phimosis can be physiological or pathological. If it is pathological, may need treatment. Physiological, you can wait, allow it to get better. So these are the things that you need to talk about first before going into radiology.
Okay, correct. Now, the commonest investigations we pediatricians subject to is sonography. So
Yes.
initially, few years back, it was said that after 2 attacks of UTI, sonography should be done. Now they have become more stringent that even after 1 attack, sonography should be done. So what findings you expect in sonography?
Yeah, I think ultrasound has to be done in every child who has a urine infection. One.
Correct.
The only thing I want to emphasize here is please do not diagnose a urine infection based on an ultrasound scan, because the common report that you get, and very often we only read the report, we don't look at the films, is there is thickened bladder wall suggesting cystitis. Now, a thickened bladder wall is because of an underfilled bladder. So if the bladder is not completely full, the bladder wall looks thick. So a collapsed bladder is a thick walled bladder, which is reported as cystitis. You don't diagnose on ultrasound. What we are looking for in an ultrasound is whether the kidneys are normal in size, whether there is dilatation present, whether the bladder is normal, whether there is ureteric dilatation, and whether the CM differentiation of the kidneys is normal.
Perfect.
Okay. And about NCU, it is in all?
No. I mean, if you go back, 1991 was when they started about all this, but we don't have time to talk about all that. Recent guidelines now say that the MCU should be done in children who have recurrent urine infections despite prophylactic antibiotics. In every boy where you suspect an obstructed system, MCU has to be done. That has to be done day 1. So forget about what the guidelines say. Whenever you suspect urethral obstruction, it has to be done. Repeated urine infections and abnormal ultrasound. So if you've got dilated ureters, you have to do an MCU. And then the other criteria are not so stringent. So abnormal organisms.
Suppose 6-month-old this child has got free flow of urine, first attack of UTI, ultrasound is normal. So far we are saying below 1 year MCU is not the criteria anymore, correct?
Yes.
Unless he has second UTI.
But there is a caveat. You are going to do a DMSA in this child anyway.
Perfect.
Until you do the DMSA, you're going to put the child on prophylaxis anyway.
Perfect. That's
that
okay.
solves your problem. That solves your problem.
Correct.
So that brings to another question: DMSA versus DTPA versus EC scan.
Right.
As
I think
in
as
previous
Dr.
discussion, it was said EC.
Yeah, I think as Dr. Sushmita was trying to point out, DMSA is a static scan, whereas EC scan, MAC3 scan, DTPA are dynamic scan. So in
Correct.
very simple terms, what is happening is you are putting the injection inside and you can see the color draining down from the kidneys into the ureters and the bladder. That is a dynamic scan. A static scan is where the color is taken up by the functioning tubules. So the DMSA only tells you that there are areas of the kidney that are not functioning. So non-functioning nephrons. Unfortunately, the nuclear medicine guy always goes overboard. He will report it as scarring or no scarring. And that's all they report it as. It is not his job to diagnose a scar. It is a pediatrician's job. So non-functioning areas can be because of dysplastic kidney, can be because of an acute infection, can be because of a scar, or can be because of other abnormalities like an acute interstitial nephritis. You do a scan with the creatinine high, you will get abnormal areas on the DMSA. So what the DMSA shows, you have to interpret clinically as to what the child has.
Okay.
And a DMSA in a urinary tract infection, we don't do an acute DMSA, we do it 6 months later to find out long-term changes so that you can decide the long-term follow-up for the child.
Okay. Now, Pankaj, this child USG showed ureteric dilatation. MCU showed grade 3 VU reflux on left side. So what are the grades of VUR and how they are important? Can you
I think
specify?
everybody knows the grades of UR. Grade 1 is mild, and
current
grade 4 and 5 are dilated ureters, tortuous ureters reaching up to the kidneys.
So the current management of VUR.
Right. So just how many pediatricians know whether they have VUR? We don't know. So the point is that VUR has been a bystander for a very, very long time. It's not necessary that VUR is the culprit. In many cases, unless there is repeated urine infections that are seen, VUR does not need to be treated. Long-term outcome does not depend on the VUR. It depends on how the kidneys have formed at birth. And if you look at all the studies, what they have missed out is the fact that the kidneys may not be normal to begin with, and they don't have any symptoms. So these are the degree of dysplasia determines what the long-term outcome is going to be. So more important than VUR, we need to start focusing on kidney function. So every child that has this kind of a picture should have an annual creatinine, a protein creatinine ratio, and a blood pressure apart from the growth monitored lifelong. That's the only way you are going to pick up whether these children are going to have renal problems.
Right. Correct.
So for VUR itself, prophylaxis is given. So 6 months to 1 year is the duration that I usually say. So 1 year without urine infections, you can stop the prophylaxis. They say high grade VUR needs more prophylaxis for a longer time. I don't think that's justified. My article is there. You can look.
Now, Pankaj,
So as I answered, Pankaj, what you're trying to say is that a VUR is not a mechanical problem. VUR is associated with a renal nephron numbers. If the numbers are less, even if you operate, the outcome may not change unless it will only prevent the recurrence of the UTI.
Yes.
So surgery is more to prevent recurrence UTI rather than to actually improve the overall outcome at the end. Overall
Yes.
outcome will depend on the number of nephrons, which will be reflecting on the urinary protein creatinine ratio. If that is normal consistently, then you have a very good outcome as an adult.
Yes.
If that shows that this protein, you need to treat it to prevent further damage to the remaining nephron and the kidney, so that you can prolong the ultimate setting up of renal failure. Am I correct in interpreting what you said?
Yes. So if your GFR is more than 50% after your, see, the biggest time where your renal function drops is puberty, because there is massive growth and therefore the kidneys have a lot of load. So I keep on explaining that again, I keep on using unscientific models, but it is important to understand if your dysplasia is severe, if you've got only 20% nephrons, you will not survive. Because in the first few years, you're going to get kidney failure. If your degree of dysplasia is such that your nephron number is 80%, you're probably going to go through life without having problems.
Correct.
Problem is where you've got 50%, you're going to be fine throughout the childhood. But when you hit puberty, your renal function is going to drop. Now, these are the children that need to be picked up, because if your GFR is more than 50, at the end of puberty, in the next 10 years, it's very unlikely you will need dialysis.
Okay. So Pankaj, oligonephron plays the important role, right?
Yes.
Now, role of antimicrobial prophylaxis in which patients,
He said
which
already.
antibiotic and how long?
So the ideal prophylactic antibiotic is something that should cover a long, broad spectrum of organisms, should not change the periurethral flora, should be cheap and all those things. The ones that are satisfy this is cotrimoxazole and nitrofurantoin. So more than 3 months of age, you can start using. Unfortunately, both are not easily available in India, so we have to make do with cephalosporins.
Now,
No, so cotrimoxazole is easily available now. Again, the syrups have come back because we use it in onco patient day in and day out as a PCP prophylaxis.
So
now syrups are free. So I'm just saying the pediatrician that syrup Septran. I mean, we can take the name because this is easily available.
Now, Pankaj, we used to get urine examination done weekly for 1 month, at 1 month for 3 months, at 3 months interval for 1 year, then at 1 year interval for 5 years. Is it so still it is?
No, so my question to you is, why do it at 7 days? Why not at 6 days? Does it mean that he will get an infection only on the 7th day? That has no logic whatsoever. Surveillance urine samples are pointless because if the child is asymptomatic and you see a pus cells in the urine, that is not a urine infection.
Okay, right. So the role of surgery in whom and when?
Recurrent urine infections despite prophylaxis in a high-grade reflux, you would offer the option of surgery.
Okay. And bilateral VUR versus unilateral VUR, any difference in management?
I think the chances of having long-term problems in bilateral VUR is higher. So the same thing, they need to be monitored. All of these children need to be monitored because there is no way of picking dysplasia in the first year of life.
So which surgery?
So, and the deflux surgery can be used, but the success rates are lower. Reimplantation can be done where the success rates are higher, meaning that you can abolish reflux. Long-term outcome does not change. You have to monitor the kidney function even in these patients. I have had patients where they have been discharged because they have not had a urine infection after 3 years, and they have come back with a creatinine of 2.4, come back with a creatinine 1.2 because they weren't monitored.
So what about follow-up with and without surgery?
In either case. So not all reflux go into problems. And similarly, all operated reflux do not remain fine. So all of them need this follow-up that I said. They need to have a creatinine, a blood pressure, a urine protein creatinine ratio, apart from the usual things that you monitor in the clinic, at least once a year. And if they are abnormal, faster.
Lifelong.
Yes.
Now, in case the MCU had picked up PU valve, how to manage?
No, I think valves is an entire different story altogether because that is an obstructive lesion. So they need surgery and they will have damaged their kidneys in utero before they have come out.
So when surgery, when?
Ideally, immediately as soon as you pick them up, you stabilize the patient and operate. You don't
how
wait.
about follow-up?
So the same thing applies to them. All children with valves need this done annually, if not more frequently.
And check
so again, Pankaj, it's the PU wall is not a mechanical problem alone. Again, it may also mean that either there is enough damage in utero or the children are born with less nephrons in the kidney to start with. These are the PU wall, and that's why the same principle as the reflux will prevail, that you need to look for protein creatinine ratio, blood pressure, almost lifelong.
Yes, as I explained to the parents that if both kidneys together can give function of one kidney, they'll be fine throughout life. Correct. If they cannot, then eventually they are going to face problems.
And here, role of antimicrobial prophylaxis?
I think the same thing applies 6 months to 1 year. If they have not had urine infections, especially if they are toilet trained, you can stop them.
Okay. And here, what is the cause of damage? Back pressure or the oligonephron?
No, any obstructive lesion with reflux causes damage by pressure. And therefore, the kidneys, even if they have been formed normally at the 5th month of gestation, will have sustained damage for the next 4 months.
Correct.
And therefore, when they come out, all PU valve patients have sustained some damage. The degree of damage is what will decide the long-term outcome.
So in general, at the end of this case, how will you counsel the mother or our pediatricians colleagues to prevent UTI?
So the commonest reason for urine infection is simple things. So if the child is constipated, in an older child, poor fluid intake, incomplete voiding, not going frequently, these are the reasons why you get urine infections. Forget about reflux.
And genital hygiene in a female child?
Well, genital hygiene works
I mean,
both
genital
ways.
hygiene. Sorry.
So if you do over hygiene, you get vulval redness.
Correct.
So repeated washing is the commonest cause of vulval redness, and these children present with what I call as a UTI mimic, and they keep on getting antibiotics throughout life.
Last
Because
question.
Yeah,
Last question is
circumcision.
role of prophylactic circumcision in patient with recurrent UTI. I forget VUR or otherwise.
No.
I mean this.
If you have proven recurrent UTIs, then do the circumcision.
Okay,
Don't
fine.
do it before they get urine infections. It's not warranted.
Perfect. I think we are running out of time, and we have maybe
Yes,
another
Nitin
5
bhai, you
minutes.
take third case, please.
Yes, Fagun.
Yeah, I think that was a wonderful explanation by Dr. Pankaj regarding the UTI. Just one point to make as far as
Yes, please.
surgery is concerned, that we need to ensure a good bladder function before we go for the
Yes,
surgery,
yes.
because many times our surgeons are quite impulsive in getting the surgeries done, and they don't check the bladder functions, and then they backfire with the reappearance of the reflux.
Absolutely. So I think we are running out of time. So we will keep nephrotic syndrome and hematuria in another session with the same experts in the coming months. But before we end, because it's almost 10:30 now, and there's a time for us to stop, we will take some common issues, Fagun, if you permit. So like a rapid fire. A newborn has not passed urine after birth. Still, how many hours is it okay if the baby doesn't pass urine? Fagun.
Yeah, we can wait for 24 hours if the patient has not passed urine. If it is
And
beyond
suppose
24
not
hours, we
pass
need
for
to act.
48 hours, then what do you do?
Definitely, we need to investigate for the, the cause for this. We need to see the dehydration, and also we need to look a ultrasound examination to see if there is any structural or other problems to the kidneys. And definitely, we need to also investigate regarding the antenatal history as well, to ask antenatal history as well.
Perfect. Now, commonly question asks that when you do serum creatinine in a newborn, it actually reflects the mother's rather than the child's kidney function for the first 40 to 70 hours. Where is the ideal time to do a creatinine in a child suspected to have some renal issues in a newborn?
So the creatinine needs to be done ideally for the first 40 to 72 hours. It reflects the maternal creatinine. So if you want to get it done after 72 hours. But to be more precise, even after that, there is sometimes the reabsorption of the creatinine. So the best time to do creatinine maybe after 5 to 7 days, which gives an optimum value of the fetal or of the neonate's creatinine values.
Okay, Fagun, the common question asked. The mother says, my baby's diapers are red stained, so I'm worried, is it passing blood in the urine?
I don't think so. If the child is fine, taking feed well, and if everything is okay, then it is most probably urate crystals which are giving the red or pinkish color to the diapers.
Now, Nitin bhai,
yes, sir.
Next 10-15 minutes, please finish third case because it is very important. So 10 minutes.
Which
third
one?
Case, nephrotic syndrome.
No, we'll take nephrotic syndrome and hematuria together in another session. This is a very long case. So we'll just finish off the last common issue, and then we will wind up.
Okay.
All right. The child is passing frequently urine, Fagun, like 20 times in a day, 30 times in a day, but very small quantity. What is this disorder? It's very common in OPD patients. Mother keeps on saying every now and then he wants to go to pee, but he passes just a little volume.
So basically in these patients, you might be dealing with avoiding dysfunction, or it could be just a functional problem. And most of the times we get the patients who have just started the schooling, or maybe has joined the school, or there is some bullying or anything. So most of the times it is basically a functional problem, but we definitely need to rule out some other avoiding common disorders like overactive detrusors, or
so
maybe
how do you know it's an overacting detrusor? Can you do a full bladder capacity and find out age?
Yeah, so basically, if you want to investigate, I think two most important things which we need to do is a good voiding diary, and second very important thing is a nicely performed ultrasound examination, which will help us to know that is a full bladder volume, a post-void residue, and the bladder wall thickness at the full bladder volume as well as in the post-void residue.
And you find
at post-void.
And you find that the child does have detrusor irritability, and his blood volume has become much less than the age. Can you help him with some simple medicines?
Yeah, so basically, most of the times, this children requires a good combination of the urotherapy as well as the pharmacotherapy in the terms of some anticholinergic medications. The most commonest that we use is basically the oxybutynin.
Okay, fine. And how long can you use it?
So there is no limit to at which we can use the oxybutynin, but most of the times we just look at the symptoms and try to see how the child improves. But a proper urotherapy, a proper toilet training is required to first of all ensure that the child is doing well, and only after that we can taper off the medicines or stop the medicine.
Right. And I think the last commonest problem we face day in and day out, and which is more a social problem and an embarrassing problem, is the monosymptomatic nocturnal enuresis. So, how do you know it's monosymptomatic nocturnal enuresis, not related as a part of other associated conditions? That's number one. And number two, do you treat all of them at what age and with what medication, or just alarm or reward therapy, or a combination?
So the monosymptomatic nocturnal enuresis could be either a primary or a secondary thing. The primary thing, mostly the patients will not be dry anytime right from the beginning.
Even
And the
once,
second,
right.
sorry, and the secondary thing might be the child is dry in the between for 6 months and has some other issues as well. So it is very, very imperative to see whether the child has any daytime symptoms or not. Because if the child is having any daytime symptoms, then it is a non-monosymptomatic nocturnal enuresis. If the child is having not having any daytime symptoms, and most of the times it is a primary monosymptomatic nocturnal enuresis. So basically there are 2 or 3, the physiology by which this acts. The most common is basically the circadian rhythm of the AVP, which occurs in these patients, in which the rise of the AVP, which occurs at the night, doesn't occur. And hence this child passes a large amount of the urine at night. So if we try to calculate the maximum voided volume in this patient, it is more than 130% of the bladder capacity. And these are the children who are best benefited by the desmopressin tablets. Yeah.
So
But
is it
on
the
the
same with
contrary,
the
if the
desmopressin sensitive patients vis-a-vis desmopressin not that sensitive? Is that what you're trying to say?
I'm not able to hear you, sir.
No, does it? So with the large volume pass, and you say more than 130% of bladder capacity, they are the ones who are labeled as desmopressin sensitive patients?
Yes, so most of the times it is basically if there is a single large void, then in that conditions, most of the times the desmopressin will work. And on the
So
contrary,
what
the child,
you give tablets or you give the melts? Or and what dose?
so desmopressin tablets are a little bit cheaper alternatives, but the melts are more preferred, considering the fact that first of all, it doesn't interfere with the food in the body because it is directly absorbed from the mucosa. Number two is that the duration of action is a little bit longer. And number three, the compliance is good because the child doesn't have to take the tablets or swallow the tablets with the water. So the desmopressin melts are preferred but the only issue is basically the cost, which is quite high if we use the desmopressin melt tablets as melt as compared to the tablets.
So what is the dose you use, either tablet or melt, and how long you use?
You start on with the dose of 0.2 milligram if you have to use a tablet, and if you want to use a melt, you start at 120 micrograms and look at the response. Normally, the child should dry in 2 to 3 weeks. If there is not an optimum response, you can double the dose. And if the child responds, then you can just stop, continue for 3 months and look at the response. If the child responds, then you don't need to stop abruptly, but you need to taper gradually and then stop these tablets to prevent the relapse of the.
So taper over like or a month or 2 or?
Yeah, taper over almost 4 to 6 weeks, and that should be fine.
And no other non-pharmacological ways of managing nocturnal enuresis?
Yes. So it is very, very important that the child should be given a good urotherapy. The child should take ample of fluids in the daytime, that is up to 4 or 5 p.m. And after that, the amount of fluid restriction has to be made. The child should void the urine very regularly, because many times we see that the child goes to the school, doesn't drink anything there. And once the child comes home after 5 p.m., he drinks lots of water and then he passes the urine by many times. So it is very, very important that the child passes urine regularly. Number three is that the constipation has to be avoided. And most of the times it is the constipation which is also a big culprit. So many times if you treat the constipation, the treatment gets, the thing get resolved on its own. Fourth important thing is timely dinner. So normally you need to know what time the child sleeps. So you need to take the drug at least 1 hour before the child sleeps. And if you're taking a tablets, there should be a gap of minimum 2 hours between the dinner and the tablet, so that it doesn't hamper the absorption of the tablet.
Sure. And any restriction of fluid just before sleeping?
Yeah, so normally 70 to 75% of the fluid should be taken in the daytime before late evenings, and after that it should be just 20-25% of the fluid, and it should be stopped at least 1 hour before the child sleeps, and till the morning the child shouldn't have any fluid. And if the child wants, it should be a very low quantity of the fluid.
And three more things, like the alarm. I mean, does it help or it actually hampers the
the alarm therapy will be more helpful in the patients in whom, first of all, the patient passes small voids and multiple voids. That is the patient who are having a small bladder capacity. Number two, the parents and the child both should be very motivated. So if the parents are not motivated, if there is a feeling of guilt in the child, and if the parents don't want to basically use this, so in that instance, the alarm therapy won't work. And if you give alarm therapy,
reward therapy for the child.
Reward therapy definitely works. Definitely, it is a part of the non-pharmacological therapy.
Mhm.
And
Anything
as far
else?
as alarm therapy is concerned, most of the times, the patient, as I told, that he or she should be very much motivated to take up the therapy. And if it doesn't fail, sometimes the combination therapies, that is the desmopressin plus alarm therapies, also do work well.
And at no time there should be any punishment given to the child.
Definitely not. No punishments.
Making
Because
him
that
wash
would be
his clothes, or
counterproductive.
yeah, so ridiculing him or telling in front of people that this child, etc.,
Yes.
should be completely avoided.
Yeah.
Unfortunately, many of these parents also were, some of them can be still enuretic, or many of them had past enuresis, so they are a little more sympathetic. So I think it is easier for them to manage a child who has enuresis.
So
Which is the
25% of the
real,
times we have a family history there, because it
correct.
is transferred
Which
by,
is
I think,
the age
autosomal
when,
dominant.
which is the age when you will really start treating early? 5 years, 6 years, 7 years? I mean,
So normally, as the studies say, that at 5 years, almost around 50%, 15% of the child are basically still bedwet, and the age increases. And the age, I mean, the percentage decreases as the age progresses. So by 12 years, it is less than 1% who are enuretic. So it all depends upon how, I mean, how anxious are the parents before you start the treatment. It happens sometimes that at 5 years, the parents are very, very anxious and they want the child to become dry. And it also occurs that at 7 years, the parents are quite okay, and they feel that the child will grow out of it after some time, because even they had grown out of it. So eventually, whether you want to start the treatment or you don't want to start the treatment, it all depends upon the parents as well as the self-esteem of the child, especially in the older children. But most of the times you can just do a simple non-pharmacological therapy for the early age group. But beyond 7 to 8 years, when the child goes to the school and when he has his peers looking into him, there are chances that his self-esteem might be hampered. In that instance, you might need to start a proper pharmacotherapy if the child is not controlled, or an alarm therapy.
Perfect. So I think, friends, that brings us to the end of this session, because we are already short by more than 12 minutes over the time allotted. So last comment from Pankaj. I see your hand raised, and after that I will conclude. Yes, Pankaj.
It's just to help the pediatricians about the overactive bladder. Apart from the pharmacology, the more important thing is treating constipation. But please ask for history of tea, coffee, cold drinks. The common history is that the parents are working, the grandparents are at home. They start tea in the child, and then the child starts that.
Correct, fine. So I think, so we started with the very basic labs which you asked, but the most difficult to interpret, and I think a lot of clarity on urine routine, which is the most important test that pediatrician need to understand, and the culture, how to collect, etc. Then we went on to some cases, the one with the PUG obstruction. Then we took the UTI, very beautifully explained that the UTI with reflux is not a mechanical problem, so also the PU wall alone the mechanical problem, but it is also do with the number of nephrons left in the kidney. So they not only need correction of the reflux for recurrent UTI, treatment of each UTI very vigorously, but also to look at the deteriorating renal function almost lifelong. And that's the way you can actually help the patient, rather than just operating them, doing a reimplantation and forgetting them. And then at the age of 30 years, they come back with creatinine of 8. And I think that's a disservice to these children, because we could have identified the proteinuria, treated the proteinuria more vigorously, identified hypertension, treated more vigorously, and so on and so forth, and maybe added some more life without dialysis or a renal transplant in many of these patients. So we have not touched upon the nephrotic syndrome and hematuria, and we promise that we will have one more session with the same expert in the coming months. We will declare the date very soon. Maybe the next month is our second round of immunization. So after that, in the month of September, if these experts are available, we'll fix up a date again, and we will discuss very important two aspects of nephrotic syndrome and hematuria. So I hand over mic to Dr. Ramesh Bajania to conclude, and thank you all those who have joined for your patient hearing, Dr. Rajubai as the guest, all other guests who are there on the Zoom platform, and all the delegates who are there on the web stream live seeing the program. And not last but not the least is all the three experts for sparing their valuable night. I would say it's almost midnight now. And of course, Dr. Vasudev, another expert nephrologist, for sitting through and listening to us painfully. So, Ramesh bhai, you can conclude.
Yes. So, thank you all, Pankaj bhai, Fagun bhai, Sushmita ben, for sparing your valuable time. Please share the recording link, which soon we'll share with all of you.
Yeah. So,
special thanks to Dr. Vasudev sir and all those who remain present and encouraged and inspired us. Yes, Nitin.
So just to tell everyone that all these webinars are archived in the Gujarat Pediatrician YouTube channel. Usually it takes 48 hours, but for those who want to see this episode, the same link will be alive and you can see it for the next 48 hours. After that, this link will expire and the entire presentation will go on the YouTube channel. Gujarat Pediatricians, please type it and you'll find it. You can subscribe to it so that you get an update on a new video being put. And after next 2 or 3 days, this video also will be available for viewing. So you can please pass on the message. And of course, we will also send those WhatsApp messages in the group, giving you the link to the Gujarat Pediatrician. Moment this entire session of today's is also uploaded on the Gujarat Pediatrician YouTube channel. So
Yes,
Sabba Khair, good night.
As Nitin Bhai said,
you.
I'm inviting all of you.
Thank
for
An
you.
this,
excellent
so much,
session.
everyone.
Pediatric
Because of my
vaccinology
weak
webinar
network,
next.
I could not intervene or contribute, but
No
I've been
problem.
listening all through, and all the experts along with Dr. Nitin Shah and Ramesh Bedani and everyone. I think this has been an excellent session. Wonderfully
you.
done. Wonderfully done.
So thank you, everyone. Good night, everyone.
Thank you. Good night.
Bye-bye.
Good night, sir.
Bye, Vivek.
Good night.
Bye.
Good night.
Bye,
Good night.
everyone.
Good
Bye.
night.
Thank
Good night.
you. Good night, everyone.